Good morning to all. My topic is comparison of clinical outcome of Fusarium and Aspergillus keratitis. Coming to background and rationale, fungal keratitis accounts for 40 to 50% of all microbial keratitis, and in South India, filamentous fungi accounts for more than 60% of all fungal corneal ulcers, and Fusarium and Aspergillus are the most predominant species. And fungal keratitis is associated with a higher risk of development of complications and is more difficult to treat. So, a prompt diagnosis and early initiation of treatment is needed for best visual outcome and to avoid complications. Objective of my study is to compare the clinical outcome in terms of ulcer healing of Fusarium and Aspergillus keratitis following treatment. Methodology: it was a hospital-based prospective observational study done in a tertiary eye hospital in Kerala. Study population were patients admitted as diagnosed fungal corneal ulcer who satisfy the inclusion criteria and study period of 1 year. Inclusion criteria was patients with fungal corneal ulcer who are culture positive for Fusarium or Aspergillus, and my exclusion criteria were the patients with other causes of corneal ulcers and neurotrophic ulcers, bilateral corneal ulcers, and patients with perforated ulcer at presentation, and patients with pre-existing corneal diseases. Sample size was calculated to be 30 from each group, a total of 60. My study variables were socio-demographic variables, corrected distance visual acuity, which was converted to logmark, size of infiltrate. The depth of infiltrate was assessed in three categories: less than 1/3, 1/3 to 2/3, and more than 2/3. Location of the infiltrate was divided into categories like entirely peripheral, partially covering central 4 mm circle, totally covering central 4 mm circle, near total ulcer or a total corneal ulcer. And the outcome variables were defined as a healed ulcer, healing ulcer, the ulcer remaining the same at the end of treatment, and ulcer which was worsening at the end of treatment. Then data collection methods: informed consent was taken, detailed clinical history by a structured pro forma was taken, corrected distance visual acuity was taken by Snellen chart and converted into logmark, and examination with a calibrated slit lamp biomicroscope was done. Microbiological testing of the corneal scrapings with 10% KOH, gram stain, bacterial culture and fungal culture reports were obtained, and a standardized treatment which was adopted from the TST protocol was given in both the groups to all the patients, and they were followed up at 2 weeks and 1 month after the initial presentation, and development of complications were noted. This was the treatment TST protocol which was given. Then coming to results, 60 eyes of 60 patients were studied, and 30 from Fusarium and 30 from Aspergillus group. The majority of patients were in the age group of 51 to 60 years. Males were more affected than females, and majority of patients belonged to the lower socioeconomic status. And coming to comorbidities, 26% of the Aspergillus patients were diabetic, and 6% of Fusarium were diabetic. And among the comorbidities, only diabetes mellitus was found to have a statistically significant association with the fungal keratitis. Then comparison of visual acuity. At the logmark visual acuity at presentation, Aspergillus had a better visual acuity at presentation compared to Fusarium. But at the end of study, after 1 month, Fusarium was found to have a better visual acuity compared to the Aspergillus group. And size of infiltrate, also Aspergillus there was larger size ulcers were found in Aspergillus group compared to Fusarium. And after 1 month also, it was the Aspergillus was more in size compared to Fusarium, but both they had decrease in the size of infiltrate. Then comparison of depth of infiltrate. At the initial presentation, majority of Fusarium were involving 1/3 to 2/3, and majority of the Aspergillus were deep ulcers involving more than 2/3. And after the end of 1 month, majority of both Fusarium and Aspergillus had a depth less than 1/3, and more for Fusarium group. Then location of the infiltrate at presentation. Majority of the Fusarium ulcers were partially covering the central 4 mm circle, whereas Aspergillus, majority of the patients, the ulcer was totally covering the central 4 mm circle. Then the treatment was given, natamycin was given in all 60 patients. Natamycin was voriconazole was given in indicated 23 Fusarium and 25 Aspergillus cases, and systemic antifungal in addition to these two were given in 12 Fusarium and 15 Aspergillus cases, and intrastromal voriconazole was given for 1 Aspergillus patient. Then treatment response at the end of 1 month, 40% of Fusarium and 26% of Aspergillus were completely healed, and 33% of Fusarium and 36% Aspergillus were in the healing stage, and the worsening ulcer were the more for Aspergillus cases were worsened compared Perforation and perforation was more in the Aspergillus group compared to the Fusarium group. An indication for therapeutic penetrating keratoplasty was also found to be more with the Aspergillus group. And coming to discussion, in my study, there was a male preponderance and 40% Fusarium and 26% Aspergillus were completely healed, compared to the parent study where also 62% of Fusarium and 23% Aspergillus had good outcome, and 10% of Fusarium and 16% of Aspergillus perforated in my study, and compared to 18% of Fusarium and 20% Aspergillus in the parent study by Chidambaram et al. And a study by Gajar et al., the time required for healing in Fusarium group was statistically less than Aspergillus. And conclusion, Fusarium keratitis had a better outcome in terms of ulcer healing and visual acuity compared to Aspergillus, and Aspergillus was associated with the higher rates of complications, and this may be due to large, deep and central ulcers at presentation, and majority of patients in both the groups were completely healed or at the healing stage and at the end of the period. Which contributes at early detection and prompt treatment can improve the outcome and prevent the permanent blindness. These were my references.
You told you have cultured, no? Which culture medium was used?
SD, Sabaros dextrose agar.
Sure.
Sure.
Then you told about depth of infiltration. How did you examine the depth?
Depth assessed with the as in slit lamp with examination, the thin slit, optical illumination, and at an angle of 45 degree, the depth of the infiltrate was identified as belonging to anterior 1/3.
Which portion of the cornea you measured? Central portion or peripheral portion?
Central portion.
Central portion.
Central portion, and most highest, more of where the infiltrate was more concentrated, that area was.
You are told now therapeutic keratoplasty needed. Did you do
indication for therapeutic keratoplasty.
Needed.
Indication, sir. I meant
Not done.
Not done. My study follow-up period was only for 1 month, so majority of the ulcers were not were not done at the end of that study.
You were talking about Aspergillus. Which species was it?
Aspergillus, all species were taken.
All means what are the species?
Aspergillus flavus, fumigatus.
Next. That's all you know?
That's all.
That's all. What is the black one you call?
Niger. Aspergillus niger.
Okay. Did you use systemic antibiotic or antifungal in this?
Systemic antifungal were
in all the cases.
Not all the cases. The patients, the ulcers which are more than 5 millimeters are involving more than 50% of the death, involving the limbus or.
Did you measure the intraocular pressure in all these cases?
No, sir.
Do you know that intraocular pressure is one of the cause for the poor healing?
Yes.
Did you use any anti-glaucoma medication for them? Topical?
Topical were given in some with indications.
What cycloplegic did you use?
Either homatropine or atropine was given.
The one with atropine would have responded better. Then how can you put homatropine in some case, some in atropine?
Based on the severity, more severe.
There is no standardization in that.
Treatment was given according to the treatment response of the patient and initial clinical findings.
Okay. Thank you.